One of my clinical and research interests is really the study of immune-related adverse events in the setting of immune checkpoint blockade. So the talk that I gave at the Dermato-Oncology Congress last week really was focused on giving a fairly broad-based overview of these toxicities from checkpoint inhibition and what they ultimately mean for the patient, as well as potential strategies to mitigate them. In general, immunotherapy toxicities are quite common. They can affect almost every organ system, but the skin happens to be one of the more commonly affected. It's also one of the easier ones to diagnose because of its accessibility. If you look at the clinical trial data, up to 40 to 50% of patients will have skin toxicities, but my lab specifically studies what happens in the real world setting, so outside of clinical trial experiences. And there, patients don't tend to come in every single time they get a small rash. They typically wait until things are particularly symptomatic and tend to present with more clinically meaningful toxicities. And in that setting, about 21 to 25% of patients actually ultimately present to their physician, be it the oncologist, dermatologist, with a potential skin toxicity. We've done a lot of the initial work trying to characterize the epidemiology of these skin toxicities. We've demonstrated that there are specific diagnoses that tend to be more common in the immunotherapy setting. So these could be very particular eruptions like psoriasis, eczematous eruptions, lichen planus, bullous or blistering eruptions like bullous pemphigoid, but also the majority of these are relatively undifferentiated, very non-specific eruptions, things like itch without the visible manifestation of rash, or from drug eruptions, quote-unquote macular papular eruptions that we as dermatologists don't love to give us a diagnosis, but often happens in a non-dermatologic setting. And these represent the bulk of what these patients at least initially present with. We've identified a number of risk factors for these toxicities. For instance, the type of cancer that the patient is being treated for, if it's a melanoma or a cutaneous squamous cell carcinoma, tend to be highly predisposing to the development of skin toxicities, but non-skin cancers like renal cancers or cancers of the bladder also do measurably increase the risk. Other types of cancers like gynecologic and head and neck malignancies tended to increase the risk by comparison to pulmonary or lung cancers. We found that individuals who are younger at the time of their immunotherapy start tend to also be at higher risk, likely due to the stronger baseline immune system and potential immune response that they have by comparison to older individuals who may have a more senescent immune system. If you are using a combination immunotherapeutic approach, so not just one immunotherapy, but two or more, that would increase the risk as well. But in general, we found there were a number of risk factors that do increase the risk for toxicity. And the goal for us is to communicate this to other clinicians and providers so that they can be more attuned to expect or not expect skin toxicity, or more importantly, be able to differentiate, is what they're seeing in front of them really a manifestation of immunotherapy-induced rash, or is it a rash that's unrelated to the immunotherapy? We spent quite a bit of time actually trying to understand the impact that pre-existing autoimmune disease has on the development of skin toxicities after immunotherapy, because one of the earlier concerns was, especially in the clinical trial data, was that patients with pre-existing autoimmunity were largely excluded from trials due to a concern that you may have a very strong immune upregulation, maybe a severe toxicity, and maybe that would worsen their cancer outcomes. But what we actually found is that overall, there is no increase in mortality among patients who have pre-existing autoimmunity, and some pre-existing autoimmune diseases may actually improve immunotherapy outcomes. What we hypothesize may delineate between those two scenarios is that if there isn't a very strong degree of immunosuppression that is necessary to control the pre-existing autoimmunity, the pre-existing autoimmune disease does not negatively impact immunotherapy outcomes. But if there is a great degree of immunosuppression, then what happens is the pre-existing autoimmune disease does increase the risk of post-ICI toxicities, which actually on overall tend to be favorable, at least if they're not severe. But the immunosuppression that is given for the management of the pre-existing autoimmunity may nullify that beneficial effect. So in the end, you probably don't have much of an effect altogether on mortality, which is actually reassuring, right? At least it shows that these patients should not be contraindicated from starting on immunotherapies for the most part. The rest of the presentation, I really focused on discussing some treatment strategies. So generally speaking, we've treated a lot of these toxicities, be they skin toxicities or non-skin toxicities, with systemic steroids, which over the last 3 to 4 years, an increasing amount of evidence has come out to suggest that systemic steroids in general can have a very deleterious effect on immunotherapy outcomes, specifically survival. And that we as a community really should try to move towards more targeted immunosuppression. So we need to understand, well, what is driving the toxicity molecularly, and can we inhibit that pathway more precisely so as not to have any unintended consequences on the immunotherapy's activity against the tumor. And in this particular presentation, one strategy that we really focused on was the use of type 2 inflammation inhibitory approaches. So for example, one of the drugs that we use quite commonly for the management of skin toxicities is dupilumab. It's a medication that blocks the IL-4 and IL-13 interleukins. And in doing so, it's actually very well poised against eczematous inflammation. It's quite effective for itch, for bullous disorders, but we've also found it to be successful in treating lichen planus and oral erosive lichenoid diseases, and even morbilliform eruptions in many cases. Again, to whatever extent there's a very strong type 2 pathway that's dysregulated, this medication has a role in treating those skin toxicities. So one of the things that was particularly salient is we wanted to first take a look and see, what is the impact of steroids in our population? Like, does it increase mortality or not? Is it consistent with what we've seen? And indeed, what we found was that there was more than a twofold increased risk of mortality among patients that use high-dose corticosteroids within a certain time window around the immunotherapy. But for the dupilumab users, there really wasn't an increased risk of mortality. In fact, there was a general trend toward a protective effect from mortality. But because we only had about 53 people in the dupilumab arm, matched 1 to 2 with non-dupilumab folks, so either those who had skin toxicities but did not use dupilumab, or who did not have skin toxicities and did not use dupilumab. Again, the sample size overall was not humongous, so we probably did not power it sufficiently enough to demonstrate this protective effect. But it was reassuring in that particular study, which is currently under review, to show that there was no increase in mortality. So, lots of different takeaways, but if I had to summarize it in a couple of sentences, it's skin toxicities are common. They're among the easiest to diagnose, and they have significant they provide us a good view into what's actually happening with the immunotherapy. And often skin toxicities overlap with non-skin toxicities, but the folks who have skin toxicity predominant outcomes actually tend to do pretty well. And if we manage those skin toxicities in a non-aggressive, non-severe immunosuppressive manner, we actually tend to maintain the prognostic benefit of the skin toxicities better than if we were to significantly impair the immunotherapy's response against the tumor by giving glucocorticoids or broad-based immunosuppressants.